history a bit as to my journey in the diabetic foot, and I'll go back to medical school where I was a student. I don't think how many years ago, probably 45 years ago at Newcastle upon Tyne, and I was inspired by the neurology there because Newcastle was very well known for neurology, and one of the best known was Professor later Lord Boulton, who was a world expert in neurology, and people came from all over the world to see him. He was a great clinical teacher and emphasized the importance of a good history and a good examination. And each week he would have a large room with students, junior doctors, senior doctors, professors from all specialties, and a patient would be brought in from somewhere in the world, and he would take a history and then call upon people from the audience in order of their seniority to do bits of the examination. Well, after this was actually a patient who was very local from just south of Newcastle in County Durham, and he took the history and then grabbed hold of an ophthalmoscope. He said, "Boulton," I was a student then, I was the first to be picked on, "come and examine this patient's fundi." So I looked in the fundi and I saw, as you can see here, optic atrophy, but it was rather difficult to see. But I said, I think, sir, that this patient has bilateral optic atrophy. He said, "Boulton, yes, you're right, but you didn't see everything. You looked, but you missed something. Why did you have difficulty looking at the patient's fundi?" And he said, "Clearly you missed that this patient has a pendulum nystagmus. And if you looked at his hands, you would see that what we used to be known as tattoos of coal dust, which told you he was a minor, therefore he was working in a very poor lighting, hence the pendulum nystagmus." So that was an introduction to good clinical observation. And Walton later, and this was a picture of him about 10 years ago, and he died in his mid-90s, and he was a warden of a college in Oxford. The last time I saw him was at the Association of Physicians, and he'd been my mentor at medical school, and he said, "Oh, Boulton, how are you doing? You seem to be doing well. Go and get me a cup of tea, please." And so nothing changes in medicine. So he was a great character and introduced me to that. And then I went to Sheffield as a junior doctor to train in diabetes and general medicine, and worked with Professor John Ward, who many of you will remember, who sadly died just 2 years ago. And he was another great teacher. And he said, "Don't try to do too many studies in research. Just take 1 or 2 research questions with urgent clinical need and try to answer these." And then he said that clinical research grows out of being a busy clinician. Listen to patients, listen to colleagues, you'll get ideas. So I came into diabetic neuropathy because of my introduction to neurology in Newcastle, and then working with John Ward, all by chance because he had some funds for a research fellow into diabetic neuropathy and foot problems. And of course, you could say that neuropathy was then, and still in some cases is, the Cinderella complication. And indeed, this is quite relevant. The shoe does not fit. And one of the commonest causes of neuropathic foot ulcers, of course, is inappropriately fitting shoe gear, which is too tight, because the patient cannot perceive the fit due to large fiber neuropathy. They cannot feel the pressure. So neuropathy, as you know, is one of the commonest causes of diabetes, and I'm talking today about chronic sensory motor polyneuropathy, which we've shown to be the strongest risk factor for foot ulcers, and around 50% of patients will develop pain, and about half of these will require some treatment for the pain. It's a distal dying back axonopathy. It's a symmetrical distance, length dependent sensory motor neuropathy. And this is one of the early studies I did in Manchester with Aris Vevis, who was then my research fellow in the late 1980s. He's now a professor at Harvard, and he was from Athens. And we found, of course, this loss of myelinated fiber density, normal diabetic neuropathy, loss of the myelinated fibers, loss of nerve fiber density. We also demonstrated abnormalities in the capillaries, in suggesting another vascular cause as well. But this is a case history that is entertaining, although not entirely related to the foot. I was a young assistant professor in Miami working with my good friend Jay Schuyler, who was also a young faculty, in 1983. And this patient was referred to me. And his complaint was that he had an abdominal swelling. He woke up one morning and found a bulge in his side. So he went to his primary care doctor, who said, "I'm not sure what this is, but you know, it could be a hernia. So he sent him to a surgeon. The surgeon examined him. He said, "You're not very sure here. I think I shall admit this patient for investigations." So this patient was admitted to one of the district general hospitals in South Miami and was 5 days investigated. He had complete ultrasound studies of the abdomen. He had barium enema, barium meal, endoscopy, intravenous pyelogram. Eventually, nobody actually took a history or examined him. So eventually they said, "Oh, this chap who was in his early 70s has type 2 diabetes. Let's ask the diabetes people." So he was discharged and sent to the Diabetes Research Institute, University of Miami, where I saw him as a new patient. And I actually took a history, and he said, "I woke up with this bulge in my side, as you see." So I said, "Did you notice anything else? Did you sleep all right?" He said, "Well, actually, the night before, it was difficult to sleep because this area of the abdominal wall felt a bit sensitive. When I lay on it, it was burning." So I thought, this is a clue here. Could this be thoracic polyradiculoneuropathy, unusually presenting with an abdominal swelling? So again, I examined the patient, and he had weakness in the abdominal muscles, and he also had hyperesthesia and allodynia, when a non-noxious stimulus gives rise to pain in the dermatomes around T6 to T10 on the right side, and absent abdominal reflexes. So I said, "Well, I think you've got unusually presenting, because I usually present with pain. But this was a motor presentation, and this was published the next year in the British Medical Journal. And I've just actually accepted for Diabetes Care another case report with MR scans of this rather rare presentation. But this tells you the importance of listening to patients, not only listening but hearing what they say, not only seeing but looking but seeing and examining." So I said to this patient, "This should resolve in 6 months," and I gave him some amitriptyline for the nocturnal discomfort. It was before the days of drugs such as pregabalin and duloxetine. And a few months later, he came back and said, "Doc, you're great. I'm better." I said, "I didn't do anything. I just know the natural history. It gets better." So there was a happy patient from me doing very little. So it was clinical observation again that led us before that, when I was in Miami, in Manchester, in Sheffield with John Ward, and we described this new clinical sign of autonomic neuropathy. And if you look at the insensitive foot in the absence of vascular disease, you frequently see these distended dorsal foot veins. And we believe this to be a sign of autonomic neuropathy leading to increased arteriovenous shunting and this increased venous return. And indeed, these veins remain distended even when you elevate the foot. Here's another one you see with a small lateral neuropathic ulcer on this fifth toe, and you see this distended dorsal foot veins. So to try and investigate this further, we had already done a study published in 1982, where we said, well, why don't we sample blood from these distended veins? And if it's arteriovenous shunting, we'd expect the TCPO2, or the partial pressure of venous PO2, not TC, venous PO2 to be elevated. And indeed, we found that. So in patients with a history of foot ulcers, there was an increased venous partial pressure of oxygen, suggesting arteriovenous shunting, and this arterialized blood returning into the venous circulation. And these therefore confirm that this is arteriovenous shunting. And in the same issue of Diabetologia in January 1982, came this paper from my very good friend, who you will know, Mike Edmonds, in London. And in a similar period of time, they'd done studies using non-invasive Doppler studies, and they showed abnormal blood flow profiles or sonograms, and they were seen only in those with severe neuropathy. Increased diastolic flow, again, was suggestive of arteriovenous shunting. So these two observations together in the same issue really confirmed these observations. So it is the warm but insensitive foot that remains very much the at-risk foot for ulceration. A year later, while still in Sheffield, I went to the meeting at the Indian Institute of Technology in Madras, now Chennai, in southeast India. And this was a meeting on the biomechanics and clinical kinesiology of the hand and foot in diabetes and leprosy. So I went with about the other members of the research team from Sheffield, and we presented our work on pressures and loads under the diabetic feet during standing and walking. But most important in that meeting was that my meeting a very distinguished and well-known individual, Dr. Paul Brand. And here he is a few years later at a meeting in San Antonio of Larry Hartless, who I'm sure you know, the sort of godfather of podiatry in the United States. And there are many well-known people on this picture. This is Wagner, and this is not the composer. This is William Wagner, who described the classification system, professor of orthopedics then at Rancho Los Amigos in California. This is the late Roger Pecoraro to his right. And there you see Roger Pecoraro here. And sadly, he died of cancer before he was 50. And he, of course, was the first, together with Dr. Gail Reiber, the epidemiologist, to describe pathways to ulceration. Here is Lee Sanders, the podiatrist with a great interest in Charcot feet, as Lee was just talking about, and also in the history of diabetic foot problems. And he was the first podiatrist to be president of American Diabetes Association. Here is Marv Levin, author or co-author with O'Neill of the first big textbook on the diabetic foot in the 1970s. And here is Paul Brand, and the person here on the edge is actually me, and it shows you the dangers of working in the diabetic foot for 30 years. And it was Paul Brand who said any patients with a plantar ulcer who walks into the clinic without limping must have neuropathy. And of course, that's a clinical observation that is entirely correct. And he described pain as God's greatest gift to mankind. And when he moved from India, from the Christian Medical Center, CMC in Vellore in Tamil Nadu, in Karigiri, where he opened a hospital for leprosy, he moved to Carville in Louisiana, the American Center for Leprosy on Hansen's disease. And increasingly, he was seeing diabetic foot ulcers. And he said, when I first started seeing diabetic ulcers, it reminded me of leprosy ulcers. He said, these are not diabetic or leprosy ulcers, these are trophic ulcers, not directly caused by diabetes or leprosy, but by an association with the disease. In diabetes, neuropathy, and in leprosy, the leprosy bacillus causes inflammation in the skin, and it likes cold areas, hence the upper and lower limbs, and causes inflammation that damages peripheral nerves. So it's not the infection that leads to the terrible pictures you see in the Bible and of descriptions of leprosy, people begging with sores on their hands and feet. So he said it is diabetes and leprosy. It's not the disease itself, but neural damage that results in the ulcers. And he proved this in leprosy. But it was always said that the neuropathic foot neuropathy is the cause of ulceration, but nobody had actually shown this. So when I moved to Manchester in 1986, we started, when we opened our new diabetes center a couple of years later, a study where we followed just under 500 patients who were screened back in '88. And to assess neuropathy, we used vibration perception threshold using the biaesthesiometer. They received education, were followed for 5 years. I'm sure you're familiar with the biaesthesiometer. This is a vibrating stylus. The higher the reading, the more severe the sensory loss. So here's the results of that study, published in Diabetes Care nearly 30 years ago. This is definite neuropathy, vibration over 25. And we showed that the risk per patient per year of developing an ulcer is about 1 in 20. This is not recurrent, this is first ulcers, compared with less than 1% in those without neuropathy, as you see here. So this showed that neuropathy is associated with a 7-fold increased annual risk of developing a first ulcer. But Brand also contributed to other areas that I was interested in. He measured foot pressures years ago. Nothing is new in medicine, it's rediscovered. He talked about the contribution of footwear to treating foot ulcers, to preventing recurrence, but also to causing ulcers in the inappropriately fitting shoe. And he even pioneered early development of pressure sensing devices to warn of high pressure. Here is Dr. Brand. This was published nearly 60 years ago. Pressure is the critical quantity that determines the harm done by the force. And we know that pressure equals force over area. And these were his previous sort of primitive, if you like, 1960 years later, transducers used in these studies, published in the 60s. Now, much later, we've worked a lot in foot pressures, and we described the pressure stat, which is a very useful device, which is a cleaner version of the Harris mat that was used in leprosy, and can be used to take the pressure of one footstep. So a patient walks over this, and you can tear off the cellophane. You've got a pressure contour map of the contours of the pressure of the foot, and you can, the darker the area, the higher the pressure. You see here in kilograms per square centimeter. And this is useful. It can be useful as an educational aid. You can give this to the patient when you're inspecting your feet, particularly look under this, the lateral side of the ball of the foot in lay terms, and perhaps under the big toe. But of course, we've moved further into much more sophisticated pressure measuring devices. This is a summary of 10 years' work that I did in Sheffield, later in Manchester. And we were the first to show that high pressures are associated with first and recurrent plantar ulcers, that foot pressure abnormalities precede the appearance of neuropathy. They occur very early. And we showed in a prospective study published in Dermatologia by Bevis, Young and colleagues, and myself in 1992, that high foot pressures predict ulcers. And we later showed that plantar callus is associated with high pressure, and removal of callus reduces the pressure. Now, more recently, we've been able to do more gait studies by friend and colleague, Professor Neil Reeves, from the Manchester Metropolitan University. And what we've shown is that diabetic neuropathy is 15 times more likely to be associated with falls compared with patients without diabetes and neuropathy. My wife, Loretta Villikite, pioneered the studies of unsteadiness being a major symptom and sign of neuropathy. We've confirmed that neuropathy is an independent risk factor for falls, and peripheral neuropathy contributes to these by the sensory component, loss of proprioception, joint position sensation, and the motor component. There is small muscle involvement in the feet in diabetic neuropathy, leading to an imbalance between flexors and extensors. So we've looked in detail at lower limb biomechanics. And the advantage of Neil Reeves' laboratory in Manchester is that we can not only measure balance, gait, pressures during walking, as you see here, but also we can look at stair negotiation. Now, if you think about it, most falls occur when going up, and particularly when going downstairs. So this enabled us to look in more detail. And here's Neil Reeves as a normal, we all think we're normal, a normal control, and these are reflective markers that are used, and the cameras can pick up and look at sway, AP, and lateral, medial lateral, and anterior posterior. Now this, if it works, it is going to work. This is a normal individual, not Neil Reeves, he's not a skeleton, but this is a normal individual. We'll come back, coming down the stairs you see on the left. Compare and contrast, as it says in essay questions, with a person with neuropathy. Look at the sway, the much more AP, rather posterolateral as well, anterolateral sway. So in a number of studies published in the last 5 to 10 years, we have described the mechanisms that underpin falls, the rate of joint torque development or muscle power development, the importance of gaze. People with neuropathy have lost proprioception, and they are much more unstable. They look carefully at the floor, they have a slower gait, and much more sway, medial laterally and anterior posterior. We've shown the higher metabolic cost of walking in diabetes. We're now looking at the role of the Achilles tendon and looking at muscle impairments as to whether, for example, physiotherapy might be helpful in helping these people who have marked postural instability. They're unsteady. Here's a recent paper we published looking at novel plantar pressure sensing smart insoles to reduce high foot pressures. This was published in Lancet Digital Health about 18 months ago. This was a study sponsored in part by Diabetes UK. And as I've already said, we've shown the importance of foot ulcers in the insensitive foot. And pressure is a laboratory measure. but can we take this out of the laboratory into daily living? So pressure feedback, first described by Patakian and others in Switzerland. And what we aim to do here was to investigate the efficacy of pressure sensing smart insoles for reducing recurrent foot ulcers. And this is the smart insole here. This is a prototype. This was just one for research studies. And it sits inside the shoe and can measure pressures in several points under the foot. And it's connected wirelessly to a wristwatch, which doesn't tell you the time, but tells you the pressures and loads under your feet. And this will alert a patient when walking if there's a particularly high pressure, as for example here in the medial side of his left foot. And the patient can then be instructed to alter gait or to rest. Well, I haven't got time to go through the details of the study, but what we showed was recurrent ulcers were reduced by 71% in those randomized to the active treatment arm, especially in those who were judged to be compliant or adherent to the therapy. They wore the shoes most of the time. A much greater reduction. Overall, the study rate was low because there's this Hawthorne effect of being in a study, and they're more likely to look after themselves. And the mechanism, of course, is pressure offloading, but it also gives patients empowerment. But it isn't only pressure monitoring. Temperature is also important. And recent studies using pressure, temperature sensing mats suggest that these can also predict ulcers. And this study by Bob Freiberg and colleagues, and this is the first just observational study, that a temperature differential picked up by this smart mat of 2.2 degrees predicted most ulcers. So now there are interventional studies that are feeding back to the patient to, if they have a persistent temperature increase, to reduce or stop walking. Lastly, just a few words to update you that has, as my friend Mike Edmonds put in this article 2 years ago in Lancet Diabetes Endocrinology, been a renaissance of new treatments in the foot care. Recent guidance published by Jeffco with ourselves and others has put in guidelines as how to randomize controlled trials should be designed. And there have been a number of properly designed trials. If you look previously, they're really not very good design studies, and there's very little evidence base for what we do in the diabetic foot. But there have been a number of recently published, well-designed trials that are informing treatment of the diabetic foot. And examples, I'll just show you one. And this, well, actually, I'll just go back and tell you that the Explorer study was using the dressing sucrose octasulfate, which was shown to be beneficial in speeding healing compared to standard of care in neuroischemic ulcers. So an evidence-based treatment. The local patch is you centrifuge the patient's own blood. You have a disc of fibrin and platelets, etc. And this has been shown to improve healing too. Other studies are ongoing. But lastly, what about infection? We know from our friend Lázaro Martinez and colleagues from Madrid that this is a randomized controlled trial. And this is a randomized controlled trial to see if antibiotics are as good as local surgery. And indeed, what they showed was antibiotics alone can be used for forefoot ulcers with osteomyelitis, but without peripheral vascular disease or necrosis. But this trial, published just under 2 years ago, was really a game changer. This is the Aviva, oral versus intravenous antibiotics in diabetic, in osteomyelitis treatment. This was a non-inferiority parallel group randomized controlled trials in a large number of hospitals, over 1,000 patients randomized to oral or intravenous therapy. Many of these patients had diabetes. And what this showed was there was no benefit of intravenous over oral antibiotics. Now, someone came from the IV treatment group to my clinic a few weeks ago and said, can I put you up an advert for IV services? I said, no, you can't, because we rarely use intravenous antibiotics. And throughout the pandemic, I've been treating patients without even being able to do an X-ray on clinical grounds, probing to bone, sausage-shaped toe, with oral antibiotics, and with good result and radiological healing shown later. So I think that we need to be very careful about overuse of antibiotics, and especially using intravenous when we can save a lot of money and discomfort and the risk of infection from having a long line in, which needed for intravenous antibiotics at home. So I'll leave you with a few thoughts. And Dominic Corrigan, for those of you who are physicians, will know the Corrigan sign of the collapsing pulse of aortic incompetence, Irish physician. He said, the trouble with most doctors and medical students is not that they don't know enough, but they do not see enough. So the message for diabetic foot care is good clinical medicine is crucial to diabetic foot management. A good history. As I said at the beginning, don't just listen, but hear what the patient is telling you. Don't just look, but see what there is to see. So Professor Lindsay was correct when he said here, for one mistake made for not knowing, 10 mistakes are made for not looking. Always look at the feet of your patients with diabetes. Now, I know the majority of you are podiatrists, and of course will be, but not necessarily. The doctor will say, how are your feet? They're fine, thanks for asking. I did that once to a patient asked to see his foot. He couldn't take his shoe off because it was nailed to his foot. That's a degree of sensory loss. Here's a meeting coming up. If you're interested, we have a virtual IDF Congress on diabetic complications in December. The abstract deadline is coming up at the end of next week. Very low registration rates, and there is a stream on neuropathy and foot problems. Lastly, we always welcome many people from Romania to our Malvern diabetic foot meeting, which we had to cancel last year, but we had last 2 weeks ago. COVID compliant with 200 people there, but sadly nobody from overseas. But our next Malvern diabetic foot meeting will be next year, because they're usually on even years. And just for your information, we do hope to welcome friends from Romania. So mulțumesc, thank you.